Hello, friends. Good afternoon to all of you. It's been a real pleasure to be invited by the DWAS and Laser, headed by Dr. Sana, to lecture on neuromuscular dentistry and how there was a certain protocol called oral ACE discovered by Dr. Derek Nordstrom in San Diego. So I would be talking a lot about neuromuscular dentistry, basics of neuromuscular dentistry, and how the science can be used and how its principles can be used in helping treat patients in pain with TMD and facial pain and cervical issues, postural issues, sleep apnea, etc. So, before we get into anything else, what is neuromuscular dentistry? Before we get into the laser part of it. Well, there are too many misconceptions out there about NMD. So let me try and clear the air. I don't know how much I could do in an hour and a half, but I'll try my best. I'm going to start with a couple of examples, of what a dentist could, or I would say should, also be practicing. So this patient, he had trigeminal neuralgia. We just asked his name. It's in my office in Cochin. So I just asked for his name and his job, and he just couldn't say anything because he was in that much pain. As usual, the diagnostic part went horribly wrong. He was diagnosed with trigeminal neuralgia because you have the same symptoms with craniofacial pain. All we did was put him on TENS, give him an orthotic, which is a splint, and in 2 weeks, he comes back with absolutely no pain, perfectly normal. Just look at him, smiling. He's got his job back, by the way. So there's another case that came to us from Austria. She had postural dystonia. Her problem was every time she tries to stand erect, her whole body begins to jerk, and she's been feeling this from the time a filling was done on her lower molar. Again, what we did was provide her with put her on the TENS, took her bite registration, left her on the bite registration material for 5 minutes, asked her to walk, and look at her. She can touch her toes and stand erect. So this is not magic. This is just physiology. It's human physiology. It's muscle physiology. And there are several other examples, like famous people, Florence Nightingale, fibromyalgia, another common term that neurologists and other doctors, pain specialists, diagnose their patients with once they can't find the cause. Paula Abdul, it seems she has fibromyalgia. Morgan Freeman, very famous actor. Lady Gaga, I love her singing. It's amazing, especially in the movie with Bradley Cooper. And she had to cancel her entire tour last year because of fibromyalgia. Our own Salman Khan, it seems, has very serious pain on his head and neck area. He's been diagnosed with trigeminal neuralgia. It seems he has undergone 2 surgical interventions for this, but he's still in pain. With all that weightlifting and all the clenching that's involved, maybe he has some myogenous muscular issues. Well, it all depends on the diagnosis, right? So Most of these patients, they have been diagnosed with fibromyalgia, cluster headaches, musculoskeletal pain syndrome, tension migraine, fibromyositis, MPDS, all vague but complicated diagnostic terms. Why? Because they're just not able to find the actual cause, which may be a simple jaw malposition. So, can we dentists treat these cases? Of course. These could be simple neuromuscular disorders that have gone undiagnosed, and most of them due to just a simple bad bite. Hence, neuromuscular dentistry, I'm going to call it NMD from now on, is high on diagnostic protocols from all possible medical angles. Our diagnostic protocols, we'll go through that, is very exhaustive, and it covers everything. We work in combination with a lot of other doctors. We'll get to that part as well. So, a bad bite virtually leads to a weak muscle, which causes postural imbalance. How do you fix it? By incorporating the principles of NMD in everything that we dentists do, from as simple as a tooth filling to a full mouth rehab with multiple implants. It's because finally the bite matters. Muscle-centric bite matters. A few pertinent questions. This is what I normally start off with during my longer lectures. So, is it really orofacial pain? Just orofacial pain, or is it the whole gamut, craniocervical facial pain? I'd like to stick to the latter because we as dentists, we've been schooled in such a way that only our final year subjects are important to us. Just as an example, when we do our first year, we learn anatomy, physiology. We even crib asking, why on earth are we even being taught about the muscles of the neck? Well, duh. You're going to know at the end of this why we were taught them. But as soon as we finish our first year exams, we forget them. Second year, same thing. We go through the whole physiology, the pharmacology and pathology. We pass the exam, finish. Third year, same thing. General medicine, general pathology. Again, same thing. We write the exam, we pass it, and we forget it. But then the final year, the rest of our lives, it's those 7 subjects. We've been brainwashed into just thinking about those 7 subjects, just all around the teeth, and we ourselves have put us into that position. Like those racehorses. I always give these same examples. So I would rather call it a craniocervical facial pain, CFP, instead of OFP. Next question. Just think about it, just to open up your minds a bit. Is it just a temporomandibular joint disorder, TMD, or is it a craniocervical mandibular disorder, CMD? Can these pains be taken care of in combination with other specialties, or we just simply use those specialties as an adjunct, So we do this and we do that and we do that, or do we make sure we do everything together? We'll get to that. We've been taught to use deprogramming splints, like the NTI and the Lucia jigs ever since our school days, dental school days. But is that going to help us? Because it's just deprogramming. What does deprogramming mean? That it's going to get reprogrammed into the old bite again. So what are we trying to reprogram? The muscles, right? The muscles control the bite. So are we going to go back again? So does it really permanently remove the cause? I don't think so. So what we need is a reprogramming orthotic. We'll get to that. How many of us actually check for microocclusion in centric and in disclusions? We use those Vijay or that Super, or I've even heard of Rajesh articulating papers that come at 140, 160 microns. Do you know the teeth have a proprioception sensitivity of up to 8 to 10 microns, which is almost the thickness of your hair. Oops, sorry, don't have it. But think about it. We can feel up to that much, and then we go around checking if the bite is fine at 140 microns. Ouch, that's not fair. All you have to do is invest in, 10, 15 rupees more and get those 20 micron, 40 micron occlusal papers. There are lots of companies that make them. I normally use Bosch. So, is our bite registration three-dimensionally perfect? So, all we do when we shoot a bite is open, close, open, close, and we ask the patient to go as back as you can, because that's the centric relation we've been taught, right? The most supra-posterior. So, is that right? Think about it. How much pressure is going back into the TMJ complex? We are forcing the jaw where it doesn't want to be. So what we do neuromuscularly is to make sure that the muscles are in the right place, so that in 3-dimension, which is not just the pitch, but the yaw and the roll, all three are in our control. No arbitrary points. It's all muscle physiology, which is measured. So a lot of us have been treating TMD for years. But think about this. What if the TMJ is perfectly normal? There is no pain in the TMJ area during palpation. There is no pain while chewing. There is no deviation during jaw opening. Radiology shows no significant degeneration or loss of TMJ space. Why is the patient there? Maybe just a slight restriction on mouth opening, or muscle pain in the masseter or cervical areas, or even a migraine. Okay, patients are getting pretty smart nowadays. So my practice is 100% TMJ, CMD, sleep disorders, and sports. So most of my patients, they know what they're talking about, and they've done their research. They understand the muscle part of it. So it's easy for me actually to treat, because it's easier to teach them. So do we still help that patient? If yes, of course. How can we be sure of? So before I say of course, you got to be sure, right? By both incorporating the technology that we have at hand and using the organ between our ears, the brain, to help decipher the technology and help better diagnose, and not just follow arbitrary protocols, right? So this is how we utilize our combination therapy and seek the help of chiropractors and ENTs as an addendum to achieve the right bite. Provided, as per our diagnostic protocols, there is no compromised muscle physiology. I mean, there is compromised muscle physiology that caused the pain in the first place. So diagnosis, very important. Because for example, with every change in your cervical vertebrae, there is going to be a change in your jaw position. So we have patients who have neck pains, and when we relax the jaw muscles with the TENS, we also need to make sure that a physiotherapist or a chiropractor who understands the neck cervical vertebral rotation, they derotate them, they get them relaxed, and that would show a significant change in jaw position, which is why we need to shoot the bite after the physiotherapist works on the neck. So if it's CMD, then it can't be just orofacial pain. It has to include craniocervical facial pain. So we now call it craniocervical mandibular disorders. We don't just call it TMJ. TMJ is just here, right? What if the patient has pain here? Again, if the EMG readings of the muscle show a wrong bite or a wrong jaw position, you've got to correct that. Medicines alone won't help. And this is why we call these disorders as CMDs and not just TMDs. Sorry, I just repeated that. We're talking about deprogrammers. So what do we learn when we were in school? We always learned to use flat plane splits or Lucia joints or NTIs in the near future. I mean, in the recent past. because we are unsure. What do those deprogrammers, why are we giving deprogram? Because we were unsure where to hold the mandible. Now we use reprogrammers like our ALF tense induced, bilaterally balanced, isotonic muscle based, myocentric occlusal mandibular orthotics. Oh, pretty long name, but in short, a mandibular orthotic with the muscle relaxed. Period. We are 99% sure of where the jaw has to be because we are recording the muscles, we are measuring them, we know where the jaw has to be. So, and by doing so, we ensure a bite region three-dimensionally perfect with the yaw, pitch, and roll, like I just explained some time back. And we use technology to check for micro-occlusion to maintain precision. So we have the Bosch occlusions, we have the tech scans, T-scan. There is also a misconception among our dentists that say that, you know, they say, oh, you have the T-scan, you can treat TMD. Absolutely not. The T-scan is just another equipment to help you diagnose. Dr. Kirstein, he came up with a wonderful protocol known as a disclusion time reduction and incorporated that with the T-scan and the bio-EMG. So it's not just one equipment. And from my experience, I use it to help with my 20% of my patients. What about the remaining 80? They have sleep issues, they have postural issues. All these also need to be taken care of. So they are not just adjunct treatment. You need to do them in combination. Okay, so now comes the fun part. No matter how malpositioned the teeth, the muscles will struggle to create a centric occlusion. Okay, just as an example. Look at this guy. What do you notice? Well, you do see his right biceps pretty hyper. He's using that arm a lot. Jokes apart, he may be using lifting weights with just that one arm more than anything else. So the right arm builds up, bulks up naturally. Compare that with this girl. Do you see the right jaw here, the face bulking up? Do you see the jaw shifting position? You know why? Because she had a missing tooth on the left lower side here. So what was she doing now? She was chewing on the right side more. So what happens if you chew on one side more than the other? Plain to see, the muscles develop. Struggling muscles are hypertonic, leading to headaches, migraines, neck aches, and shoulder aches. And mind it, when this girl comes to you for replacing that missing tooth on the left side, you're going to be giving her the implant or the bridge or even a removable denture on the same faulty bite. Think about it, okay? So you got to be extra careful because you don't want to be creating craniofacial pain. So be careful, please. Anyway, hence the treatment protocols have to be all-inclusive and all-encompassing. This is when neuromuscular dentistry comes to the fore. Why? Because you're pretty sure. And why are we sure? Because it's all measured for increased precision. We're just measuring more. It could be CR, it could be CO, it could be Pankey, it could be Dawson, it could be anything. Just make sure that the muscles are happy there and just measure them. There's nothing, there's no harm out of it. And that's all neuromuscular is about. So, he's known as the father of neuromuscular dentistry, Dr. Bernard Jankelson. That's from where everything came up. This is in the 70s. His motto has been, if it's been measured, it's a fact. If it's not been measured, it's an opinion. Obviously, right? It makes a lot of sense. It's not rocket science. It's logic. If you measure something, there you go. And there's like thousands of research bases and research papers out there, and it's just sad that people are not finding enough time, and we are still not taught about all of this in our dental school. I don't know why. We are still stuck with the same same old stuff that we are taught. For example, the psychological factors and stress more than anything else. So the primary aim of neuromuscular dentistry is to keep the stomatognatic system happy. Now, what is the stomatognatic system? It's the muscles. Oopsie. Sorry. It's the muscles, it's the teeth, it's the airway, and the joints. When all four are in synergy, the patient is happy. And to get to this, for every patient of ours, we take into consideration not just the muscles and nerves, but also the ligaments, fascia, airway, posture, in combination therapy, and not just as an adjunct. Very important, combination therapy. And we understand that the masticatory muscles, which position and connect the mandible to the skull, should be the focal point of correct occlusion. Very important. It's the muscles and not just the teeth. Okay? Because this is the theory that we've learned, occlusion is maintained by activities of the masticatory muscles, which are controlled by the neural integration of feedback from the peripheral proprioceptors, which is our teeth, and the reflex mechanism back from the CNS. So, teeth, muscle, bone, joint, airway, right? So, everything has to be known. Now, when you talk about muscles, what do we know? Just the four muscles: temporalis, lateral pterygoid, medial pterygoid, masseter, muscles of mastication. Oh, boy, were we wrong. Look at those. Well, it's not necessary that you should know where their insertions and their attachments and everything have to be, but you should be aware that all these muscles also are important in your jaw position, your hyoid, your airway, because every time you play with your teeth, you give a filling or there's a high point, there is going to be a compensatory change in jaw position, which is going to, even by a fraction of a millimeter, it would change other factors in your head and neck area. And these are the kind of patients over a long period of time, they end up with pain. They are not going to come back to you for your headaches, for those headaches. Why? Because why would they want to come to a dentist, right? They'd rather go to the ENT or the neurologist. And then they're there for years on end on medicines. They're stuck virtually. Anyway, I'm just letting you know. Ligaments, same thing. I always love talking about the pterygomandibular raphe, because guess what? The superior constrictor muscles of the pharynx and the buccinator attached to that same raphe, that single ligament. If there's any pull on one side from the buccinator, there is going to be another pull on the other side with the constrictor muscles, right? So if the buccinator pulls a lot, guess what? The airway constricts. You have sleep apnea, right? Fascia. All these fascia are connected to each other, right? Your whole body. And with us, this is something new actually. You see the deep front line? That virtually starts from the lingual frenum. I've been seeing a lot of cases where the lingual frenum, when they're wrongly attached, they create a lot of pain on the body, mainly on the feet. So if, so now tongue ties are like an integral part of our protocol, and we use the lasers to, to get rid of them. It's become a very important part of our protocol. The trigeminal nerve, it's known as the dentist nerve, comprises 60% of all neural tissues of the cranial nerves, right? So along with the spinal accessory that connects with the neck muscle, which is also important to us, and the auriculotemporal nerve, which is encompassed in the retrodiscal tissue, these three nerves are the ones that we need to look out for when you're treating any of these TMD patients. So, hence, a malocclusion can cause neuromuscular disorders whose symptoms could be ascending, where craniofacial pain is caused by other physiological factors like a short foot or a bad hip or a ligament tear on your knee, or they could be descending, wherein a malocclusion can be the cause for other physiological disorders down there. So you got to be very careful again with your diagnostic protocols. I keep thinking about this one patient I had during my training in Italy. He came with a bad back and he had a couple of surgeries, not get fixed. He came to us for some dental issue, but then my professor, he suggested, maybe we could try something. We tried. He got a little better. Then we met a podiatrist, someone who checks your feet, and found that his right foot is 6 to 8 millimeters shorter. So finally, he got better with an orthotic in the mouth and a foot orthotic. Otherwise, the pain just wouldn't go, no matter the 2 surgeries. So this is how you think holistically instead of medicines. So let's understand the physiology of the most common symptom and the initial symptom of NMD, which is, TMD. What is it? It's a click, right? So let's talk about the physiology of a click. So first of all, you need to understand what is the disc. I haven't got into the anatomy of all of that because it would take a lot of time. We teach all of those at our courses, which we do once a year. You can get back to us on our website, tmjindia.com, or on Facebook, anywhere, not a problem. It's easy to find me with a bald head. So anyway, so I haven't talked about the anatomy of TMJ, but all you need to remember is the disc, the articular disc, is literally a continuation of the superior head of the lateral pterygoid muscle. So if any muscle gets hyper, they shorten and the disc comes forward. How does that happen? Just as an example, suppose there's an occlusal prematurity, a high point, okay? What does what happens? So it sends a proprioceptive signal, a noxious, a bad signal to the brain. And every time the patient closes the mouth, this bad signal keeps coming, and the brain, gets a response known as avoidance conditioning. Basically, avoid the high point, and that becomes an engram. So the jaw shifts in position, like we saw that girl with the right side hypertrophied face. Now, a constant change in jaw movement would end up with chronic muscle hyperactivity. Naturally, one side of the muscle is working harder. If there is hyperactivity, because there is going to be a change in homeostasis, that is going to end up with excitation of RAS. Remember RAS? Yep, again, first year physiology, reticular activation system. I'm not going to the depths of it. It involves the pain spasm cycle, and it deals with the muscle hypertonicity, which ends up as trigger points. Now, when a muscle hyperactivates, means it functions more, it shrinks, it shortens. A muscle normally bulks up. When it bulks up, it's basically shortening. Any shortening of the muscle, especially the superior head of the lateral pterygoid, is going to pull the disc out of position. So when the disc is being pulled out of position, it's going to come out, right? And lo and behold, you hear your click. So when it comes out, you hear the click. It goes back in, closing back in, goes back in, you hear a closing click. Well, what happens if the occlusal prematurity remains and the signal remains? In that case, the muscle continuously becomes short and the disc is permanently forward. So you have internal disc displacement with reduction and without reduction. You might have heard of all of that. So I'm not going to the depths of it. But basically, a without reduction case, when you give them an orthotic, the patient is going to come back to you in 2 weeks saying, oh my God, I'm hearing a click again. What do you do? So actually that's good news because the disc is now coming back into position. And then it becomes normal again. The patient might need a couple of other orthotics, 2 more orthotics maybe, or maybe 1 more. But every patient is different. There is no set thumb rule. I keep saying NTR. There's no thumb rule. Okay. Just want to let you know. So extraoral signs are headaches, migraine, clenching, bruxing. So most of these are deep bite signs when a patient comes to me. Because I practice only pain, it's easier for me to know what the cause is. But if you're doing general practice and if a patient comes to you, maybe if you see a deep bite, you ask the patient, ask that person, do you have a migraine? The patient is going to say no, because he might be wondering, why is the dentist asking me all of this? So, but these are the kind of things that you need to look into a patient's mouth, not just the teeth. Again, most of them are signs of deep bites, right? The high palatal wart because of faulty tongue posturing, the narrow arches, maybe mouth breathing. So, when I came to India with all of this back in 2006, I was confused because no one told me how to, there was no guiding force here. So I had to come up with my own protocol with some help with my partners. So we have centers in Kochi, Bangalore, Mumbai, Delhi, and Calcutta. I keep traveling all over. So I kind of feel like I'm plane sick or airport sick now because I'm stuck at home. I've never been home for this long. It's almost like 45 days. Oh my God. Never been this long at home for at least 8 years now. So it's a welcome change. I'm enjoying no problems. So basically Netflix and chips. So what I'm trying to say is I had to come up with a special protocol to help these kind of patients. Our diagnosis has to be ultimate, and that's where we started up with questionnaire, the radiology, the TMJ and muscle palpation. We check for cervical rotations, intraoral and extraoral examinations, cranial nerve screening, heart rate, voltage, and capnography are used for our sports patients. Then we have postural examination and sleep study, blood examinations. An ENT and a chiropractic consult is almost a must, absolutely. So this is our initial questionnaire. Those are new ones. We look at a lot of stuff, right and left weight. We use a digital MAT scan. Again, we use equipments to measure so that we have more diagnostic criteria to work with. So we go through the headaches and neck pains, trauma, mouth opening issues, grinding, clenching, sleep apnea, bruxism. The stop bang questionnaire is on your right. We do a very in-depth cranial nerve screening. We ask the patients to point out their pain symptoms. We go through palpation of all the muscles, the cervical vertebrae. We look at intraoral signs, the posture. Then we have our protocol, which we will go through soon. And last but not the least, and most important of them all, is the informed consent. So we have all of this at all our white bite centers. Oh, we are, by the way, the white bite craniofacial pain care. That's our centers. So radiology, ideally MRI, real-time dynamic with TMJ coils. Unfortunately, I think there is just one unit that I know of in the whole of India with those capabilities. I think in Harvard, I'm not sure. Because of its unavailability, I normally stick to CBCTs. I have had my students telling me in certain areas, they don't even have a CT unit, so they have to make do with X-rays. So we let them know how to look at an X-rays as well. So in a lateral step, we're virtually looking for the airways. So you can see how a patent airway is here, and here you can see how the airways are getting occluded. In an OPG, we're looking for lack of space, and you can see how the insertion line is kind of deep here. It's, again, form follows function. So that patient would be clenching on the left side or chewing more on the left side. Well, actually, yes, you can see this gap here on the right. So maybe that patient wasn't happy, the foot impaction, so he might have been chewing more on this side. So you would find that difference in the insertion line. These are all things that you need to be aware of. We look at open and close condylography. You expect the condyle to come out. That denotes a proper movement of the condyle. that's good news. If it doesn't, bad news. CBCT, I normally try to avoid the stitched views, but my earlier units had a stitched view. So, but no matter what, we can still find out arbitrarily how much space is there between the two. But basically, again, we can find the Ellis cyst, which is cyst formation here, showing degeneration. Beaking. Beaking is, again, it's like the condyle forms a beak. Again, form follows function. It's basically a superior lateral, the lateral pterygoid dragging the condyle because of the pull. So it beaks up. It's just common sense, it's logic. Area analysis, since the CT has come in, you can see how we can measure the airway. More than the total volume, I normally opt for the thinnest area because that's the most dangerous. The thinnest area should not be less than 150 to 200 millimeters square. So you can see here this patient, and this is while standing, so just think about it. It's like 70 when he was awake, and post-treatment with the DNA appliance and expansion, he's almost up to 159. Amazing recovery. So we use a lot of appliances and not just mandibular advancement. I'll get to that when we're talking about sleep. MRI, yes, you can see very clearly. MRI is the ideal way to go about it. Like I said, unfortunately, we don't have the right MRI units in India. So let's hope we can get one soon. Then we go straight to the patient. We do TMJ side pole palpation, basically trying to feel for the condyle movements. We do a rear pole palpation to see how much posteriorly how retrude the condyle is. Patient normally jumps in pain if there's a problem. Then we look for cervical rotations to see whether the C1 is rotated more to the left or the right. Then we look at muscle palpations, temporalis, masseter, digastric, the sternocleidomastoid, occipital, the scalenes, the traps, the scapula, the lateral pterygoid, and the medial pterygoid. So all these are taught at our courses. So intraoral examinations, I'd rather go into an example straight. You should be aware about the Malampati tongue position classification. Friedman is an American who added his name. Otherwise, the poor old Indian Malampati would not have become famous. So basically, you need to be in 1 or 2 because 3 and 4, you can't see the airway at all. You should be able to see the tip of the uvula. If you can't see it, then the airway is pretty much narrow. And if the airway is narrow, breathing is dysfunctional. Just as an example, you can see this case. The first thing you see is the lateral scallop tongue. Guess why? People would call it a huge tongue, macroglossia, but I would rather see it as an enforced one because this patient had undergone fixed orthodontic treatment, and there were extractions done, and you can see the bicuspid drop off leading to a deep bite, and the jaw space has, the teeth have come back, so the intraoral space for the tongue is reduced. What does the tongue do? It pushes whenever it can, and that pushing leads to the scalloping. And to make it worse, they're given fixed retention. Most of these ortho patients are given, I don't know why fixed retention has become a permanent staple of orthodontic treatment. It should not be done because the sole reason why even I've done that mistake. So the sole reason why we give appliances to stop the beauty from changing, because you bring the teeth back, you don't want to come back. So why are the teeth going back out? Why is it relapsing? Because we did not take care of the cause in the beginning. Mouth breathing, something wrong. Maybe the nose is bent, or the adenoids, or tonsils. There's something going wrong. That needs to be addressed first. Abfractions. So That's a very common cause. So when the tongue is pushed back, and you can see all these scallopings, you can see how there is attrition of the teeth as well. But most of the attrition happens on the cervical margin, which is why we call them abfractions. Why? Because the patient is clenching. Why is the patient clenching? Bruxism. Why is the patient bruxing? Because the tongue, when it goes back, especially during sleep, it blocks the airway. And to open up the airway, the physiology of the human body is such that the tongue, the brain basically tells the tongue, go forward. As it goes forward, you clench. So every time there is a desaturation, oxygen desaturation event, we check our sleep studies. We'll get to that. I'll talk about it when we are there. So in short, every time you clench, there's going to be an abfraction. These are not toothbrush abrasions. Please never tell your patients again that. Most of these patients are given night guards to stop them, but all the night guard does is protect the teeth from further deterioration. It is not stopping the CMD from happening. So the patient anyway ends up with pain. So you can see the lingual frenum, that needs absolute correction. You can see the labial frenum. You can see how the tonsils are pretty hypertrophied and post-surgery. You might have heard of ADHD, attention deficit hyperactivity disorder. So most of these cases are now, instead of being given drugs, they are now being, the first line of treatment is now adenotonsillectomy. ADHD is virtually another name for sleep apnea, UARS, upper airway restriction. There's a lot of stuff, so I'm just running through all of this. So the advantage of working in combination with all of these allied specialities is you get to see beautiful pictures. So this is what an ENT that I work along with sends me. So you can see this is the epiglottis. This is when the patient is sitting erect. This is when the patient is lying down. You can see how the epiglottis falls back and the airway closes down. And here, this is the patient lying down with the sleep appliance. So the airway remains open, okay? Just as an example. Now, tori. I have been seeing a lot of tori because I've been noticing them, and I've been taught now that tori is actually a physiological response to make sure that the mandible, the bone doesn't break due to those excessive clenching forces caused by bruxing. So is the case with buccal exostosis. So is the case with palatal tori. And the amount of tori we see in patients with sleep apnea are huge. You can see these patients. You can see this patient, for example, all this attrition. You can see those abfractions there. Look for those tori. You would see them. Behold, there's no use just getting those tori out. You got to make sure that the patient doesn't clench anymore. There's something new that we've been incorporating. So most of the time, when we look at the uvula, there would be a left or a right shift, or maybe even pull back or something. We've learned that it's the vagus nerve that causes that problem. So all you have to do is tickle that, train the muscle, train the nerve to get it functioning again. And how do you do that? Just use a long QT and tickle the uvula 3-4 times a day, and in maybe 2 or 3 weeks, the vagus is back to functioning. There's something new, and we have incorporated all of this, not just as cranial nerve 10, but all 12 of them. Again, you need to remember those cranial nerves, first year anatomy. Before, we used to shoot bites without them, and now we shoot bites after doing them. So you continue to learn more new physiology, which would affect the jaw position, and it's been amazing. And these are things that we dentists need to know. Heart rate voltage, it's a little more advanced. We check for the heart rates, which is during sympathetic and parasympathetic. So you need the parasympathetic functioning more when the patient is upright, because that's when the patient is. So mainly for sports guys, we'll talk. You'll learn more about this when you come to our courses. We do a postural examination, basically make a grid, stand in front of the patient. The patient will stand in front, and we look if there is a head shift, a shoulder droop, a leg rotation, a hip shift, forward head positioning. So then there is another beautiful gadget that we boys love our gadgets, right? So it's known as sonography. We have the JVA and the electrosonography, different companies. Treatment modalities: surgery, arthroscopy, injections, Botox, acupressure, night guard, physiotherapy. But I would always stick to NMD. Why? Because it literally is the way to move forward. The mandible really wants to move forward. You're holding it back. It wants to move forward. So let it go. Let it go. So any of the TMD symptoms can be caused by having the resting position of bites being off by less than a millimeter, or due to interferences of a fraction of a millimeter, like a high point or something. So this leads us to the search of the elusive myocentric occlusion, not just centric, myocentric. So how do we achieve the myocentric? The aim is to create a muscle-balanced, physiological, bilaterally symmetrical myotrajectory. So what's a trajectory? It's kinesiography, it's kinesiology, anything that has to do with movement of jaws, right? So when you open and close your jaw into centric occlusion, that is your habitual trajectory, okay? If the habitual trajectory has on its path of closure a high point, whoops, it moves. So now suddenly this is your habitual trajectory, right? Is this good? No, it's bad. So what do? We need to relax these muscles. How do we do that? We use a TENS unit, or we do DTR. And once we do that, basically we are getting those muscles relaxed, and we are creating an involuntary pulse with the muscles relaxed. Okay? So this is your myotrajectory now. Let's do it sideways. So if this is your habitual trajectory, this, once your muscles are relaxed, you go into a myotrajectory. So this is your myotrajectory. You want your teeth, your jaw to finish on this trajectory. Okay? It's not easy to learn, to understand that on this, but I'm just trying to make it as simple as possible. So again, we did the right bite protocol. How do we find out what is the protocol? So basically anything beautiful in this world, on this earth, follows something known as the golden proportion, which is 1.618. So Hank Shimbashi incorporated that into the dental architecture. So all you have to do is multiply 2.08 into the width of the central incisor. That would give you the ideal vertical dimension of that human being. Okay, so in MIP, okay, so when the patient is in centric occlusion in MIP, you have a VD. Okay, so what does the right bite postulate say? The golden vertical, okay, is 2.08. Suppose the width of the central incisor is 9 millimeters. Okay, so the golden vertical would be 18 point something. For example, let's take it at 18. But what if the patient is in pain and the vertical, he has deep bite and his VD is only 14 mm? What do you have to do? You have to add to the teeth. So it is addition NMD. You have to get into 18, right? So you got to add. So that is addition NMD. What if the patient, the GV is 18, but he's an open bite case? So his VD is around 21. So what do you do now? You can't add anymore. You got to reduce. You can't just chop off the teeth. That's why we incorporate protocols like the DTR and equipment like the T-scan and the occlusions to find out where exactly you got to reduce. I've had patients who, where the dentists have just chopped off teeth. No, don't do that. If you do not have the equipments, don't bother, because you need to make sure that the muscles are fine as well. Okay, so if you're doing it, do it the right way, or don't do it. Please refer. So addition NMD involves increase in VD with orthotic construction and either with FMR. Oh, and I forgot the most important. I didn't write the most important thing. Orthodontics. That's my favorite go-to treatment protocol, because you maintain originality, right? Reduction in NMD involves decrease in VD with occlusal recalibration and chronoplasty. Okay. Nearly 80% of all NMD disorders are positive GV. Why? Because they're deep bite. Most of the deep bite cases end up with facial pain and hypermasseter and neck issues. So, which is why most of our patients are deep bite, and we do addition NMD. So, what is the protocol? We use the TENS, kinesiography, orthotic, microocclusion, and here is where we come to add the lasers. Okay, so there's something known as oral lace. I'll get to that when that slide comes up. So basically, to reprogram the muscles, we need to first deprogram them, okay, and then program them. So all this while we've been using jigs to deprogram because we are assuming what the position should be. So we're just asking a patient to bite on something. No, you don't have to do that anymore. You have specific equipments to do that for you, okay? You have patented TENS units for this. You have the Myotronics units, you have the bioresearch units. It doesn't matter. Okay, they all follow the same principles. People say they use the medical TENS units. No, they don't work the same way. Why? 4 reasons. First reason is ultra low frequency, 2 to 4 hertz. That's it. Okay. Second point, antidromic. Instead of going just to the muscle, so if you go to a physiotherapist unit and they use a medical TENS unit, you would have only that muscle twitch, only that muscle relax. Okay. No, you need all the muscles. So what do? The pulse has to go straight to the nerve, and then that nerve supplies all the muscle of the head and neck area. It's that simple. Third point, bilaterally simultaneous pulses. People say I use 2 units on both sides. You're not God. It's impossible with your tactile skills. You're not God. You cannot do it together. It's impossible. And at 1.44 seconds. Now, this 1.44 seconds is very mathematically intriguing. It's a trigonometric principle where the actin and myosin fibers form 60-degree angle for proper firing length. Now, you have TENS units that incorporate each of the 4, okay? But there are only these 2 units, these 2 companies that produce these units because they're patented, with all 4 together. With all 4 together. So, no other unit is going to give you the right readings. So this means instead of a single muscle getting twitched, all the muscles supplied by that nerve are getting pulsed and they attain isotonicity. So, the TENS electrode placement. We normally place it in front of the ear because that's where the facial nerve and then much deeper the trigeminal nerve travels. So all the muscle, which is 95% of the muscle, the head and neck area, supplied by these 2 and the cervical, spinal accessory. So we place it at that point, which is known as the Prabhu's point. It's on the anterior, it's in the junction of the superior and the middle triangle. So once these the unit is turned on, the muscles get relaxed, they twitch and they get relaxed, and it's a group action, not just single muscle, but all the muscles. So this is where we use oral lace. It's a technique using low frequency lasers on fascia and hypertrophic muscles to relax and attain isotonicity faster. And I use it for really patients in pain with chronic pain and terribly in pain, so that I attain isotonicity on day 1 itself. The protocol was designed by Dr. Nordstrom, like I had mentioned earlier. So it's a simple diode laser, 808 NM LLLT. Sana could explain more. It's first applied on the skin to check if the patient can withstand the heat, and then along the length of the mandible. So this is how the protocol goes. So and then we go 1 second, and then we go along the length of the mandible from the TMJ all the way to the symphysis mentae. Along the fibers. So we're looking at the insertion points of the temporalis, the masseter, and then similarly on the other side. It's helping the TENS unit. So what this does is basically relax the fascia that supports the muscle so that the pulse of the TENS goes faster, reaches faster to those muscles, and they relax easier and much more quicker. And then we have it on the platysma and the sternocleidomastoid. Again, very important muscles in neck position, which would help in change in position of the jaw. And then we follow it up with an application on the nasolabial fold and circular motions around the orbicularis oris. We make sure to apply a lot of Vaseline on the lips, because otherwise there would be scarring. The lips just dry up too soon. So we also make sure it goes along the philtrum to the tip of the nose, because that's where the attachment happens, and all around the neck, the lip. And then we go along, we open the mouth and we go along the inferior labial and superior labial sulci, and extending to the vestibule. This is Dr. Derek Nordstrom himself. We have an organization called ICMO. We do our conferences every 2 years, and Dr. Derek was supposed to have been here. Our conference was supposed to have been on March end, but thanks to the corona, it's now postponed till September, hopefully. And then we finally finish it with an application on the lingual frenal area. We ask the patient to bring the tongue up and do it on the frenal area, both sides, bilaterally. And then on the soft palate, followed by the hard palate. So this protocol should naturally be done before the ALF TENS unit is activated, because you can't do it with the jaw jumping up. And the protocol is utilized only on chronic, long-standing pain patients to help attain isotonicity on day 1 itself. I would do one thing, because there's not enough time to talk about this. This was an entire day lecture, so I try to squeeze it in 2 slides. So I'll try to get the hard copy or an article on this regard, and I'll give it to Sana so that she can share it with you. So once the muscles are relaxed, again, we need to measure, we need to be sure. So how do we do that? We use EMGs. So these are pre-TENS EMGs, and these are post-TENS EMGs. You can see how the muscles are relaxed. And this is the trajectory, the computer scan that we see on the computer screen. This is the neuromuscular trajectory, and this is the habitual trajectory that we were talking about. Okay. So the jaw has now come downward and forward. So this is how precise we can be, because we can see the muscle readings along with it, right? This one box is 1 millimeter square. So the myocentric occlusion, the occlusion can be anywhere within the square. Imagine, anywhere. So if you're 0.1 millimeter out of it, you still end up with pain. So why would you want to take that risk? 50% flat plane splints. This is why you don't have to give deprogrammers, because we have equipments. We can find out where the actual position is and reprogram the muscles to bring the jaw to the right place. Okay. So I, as a test, Gail, wonderful guy. Back in the day, he came up with a theory that the 4x7 position is most ideal. Is this true? I don't think so, because if this patient's muscles are happy with the condyle in 5, or the unnumbered 8, or even in 6, How could that be wrong? Because finally, you cannot have an arbitrary position. It's the muscles that decide where this condyle has to be. Condyle has to be, it's controlled by the muscles, right? That's the basic take-home point. So once we have that on the scan, we can go and shoot the bite live on that scan. The bite is sent to the lab. We have a lab because there were no labs that were ready to help me back in the day. So I had to create my own lab, and now we are fully equipped. We are the official lab for the DNA appliance, the ALF, the quick splint, the myomunchi, a lot of other stuff that are not available in India, but that helps our patients. So I normally give the quick splint because it takes around 2 to 3 weeks for the orthotic to come back in, the final orthotic to come back in. So we give them a quick splint on the same myo trajectory. Okay, it's a flat plane, but it's not given on the simple bite. It's given on the myo trajectory. So that's how we fabricate the orthotic. It's an anatomic orthotic. It looks just like teeth. We give it to the patient. The patient wears it for 6 to 8 months. We ask the patient to remain on a soft diet for like 2 weeks so that they understand where the jaw has to be. They get used to the orthotic. And then we call them in for bi-monthly adjustments. First with a 20 micron paper on centric occlusion, on MIP, and with canine disclusions. And we confirm that with T-scan and occlusions for precision, maybe later in the 3rd month or 4th month, depending on the patient. We check with EMG for muscle tonicity after 6 months. If the patient is really bad, then they may need 1 or 2 more splints. Now, once the jaw is in the right place and we've checked and the patient is off pain, normally the pain goes away in 2 weeks' time. And if the once pain goes away, the remaining time is for stabilizing that jaw position with the orthotic. Once that is done, we ask the patient can't wear that orthotic lifelong. So we have to go to phase 2. So this is where the tricky part is. So the minute you remove that orthotic, the jaw is going to go back into the old position. We don't want that to happen. Now, this is where we use our dentistry skills, okay? So we maintain that jaw position. How? If you have teeth, supraeruption of the teeth, orthodontics, best. I'll show you an example of how our typical case goes by. If there are no teeth, full mouth rehabs. Now with digital smile designing, I think we're the only guys who do digital smile designing with a neuromuscular protocol. You know, or the patient wears it lifetime. Get the picture? So this is all about adhesion NMD. Now, if the golden vertical is less than the VD, you got to cut teeth, right? Where? Reduction NMD, the J5 and the T-scan. So the right bite protocol incorporates the DTR with the J5, something that Dr. Curtis Westerson came up with, and we started incorporating to our practice. We talk about all of this, we teach all of this at our courses. So sleep apnea. How did I get involved in sleep apnea? So most of these patients I was treating in my earlier days in 2006, 2007, 20% used to come back with pain again. I didn't understand why. I did some digging and research. I found out it was sleep. So it's not just sleep, it's a whole physiology behind sleep. So if there is sleep apnea, there is bruxing. Bruxing leads to hypermusculature. If there is sleep apnea, there is the trigeminal cardiac reflex. There is the AHI increase. There is the pituitary, the HPA axis, the hypothalamus pituitary axis getting activated. So there are a lot of other physiology getting involved here, and which releases a lot of other dopamines and other hormones, which causes more pain to the patient. So we need to stop those desaturations from happening. Now, what are these desaturations? So what is obstructive sleep apnea? It's in the name, obstructions during sleep that would lead to an apneic event, which means you can't breathe, okay? Obstructions in the airway. It could be nasal obstructions, so we send to an ENT first, get them corrected off, like a DNS or adenoids or tonsils or hypertrophic concave or, blockages. and then we treat this. So if the airway is blocked like this, what happens? There is not enough oxygen getting into your body. If there's not enough oxygen, there's not enough carbon dioxide going out as well, because that airway is blocked. Okay, and this is while the patient is sleeping. So when the patient head is back, due to gravity and fat, a lot of other causes, the airway blocks down even more. So this leads to an event, a point of time during sleep when the oxygen is below 97%. This is known as an oxygen desaturation event. If the patient continues on this, he's going to die. So sleep apneics, if you hold on to them, 20 years time, you're going to have your first cardiac attack. But I'm talking about pain, right? Why is the pain happening? So as a reflex mechanism, the brain, the hypothalamus, the awakening center, it recognizes this problem and it tells the tongue, go forward. As it goes forward, it drags the jaw along with it and the patient clenches. Now, this clenching force is huge. So we have proof. I will get to that when you're talking about how as to when night bruxing is 3 times more powerful than, more stronger than your normal daytime clenching forces. I'll show you that. So again, it's all about diagnosis. How do you diagnose? So we have a questionnaire: snoring, waking up during the daytime. So every time a desaturation happens and you clench, your sleep breaks. Some people awaken. There is blood pressure variation. There is a physical exertion dyspnea. So we have to diagnose. This is what I used to do till 2 years ago. It's a simple watch pad unit. Ideally, this is what we've learned to do, the polysomnograph with all those wires. But just think about it. When you're doing a sleep study to record the sleep, for that the patient has to sleep. So with all of this, it's impossible a person can sleep. This I use right now only for research papers, but otherwise I don't. And now I don't use them at all because I have something known as the GemPro. It detects what exactly I need to know, right? So this is what you get from a conventional polysomnograph report. So you can see the desaturation here. So 8 to 9 desaturations means 8 to 9 clenching. So there's enough research paper that proves that. I'll show that later. And here you have the AHI and the RI pretty high. It needs to be below 5. So sleep bruxism, right? Are we actually treating sleep disorders? So how many patients come to you for purely OSA? For me, hardly, because I am into pain. So maybe 5% of the patient, maybe 10 max, not more than that. So aren't the patients coming to us purely for pain or occlusal dysfunctions? So how can we then depend on conventional PSGs for diagnosing sleep bruxism that majority of the time, end up with very common symptom, morning headaches. So most of these sleep apnea patients have morning headaches. They're really stuck. Even the conventional CPAP units won't help them. So in a PSG, there is the RMMA, it's the rhythmic masticatory muscle activity. That's what detects whether the patient is clenching or not. But that just denotes a muscle movement. Patient moves like this, it shows us a spike. It doesn't quantify. We need to quantify. So do we need another equipment? Well, yes, of course. So this is what the GemPro does, okay? So you can see. I give an example like this to my patients. When you normally throw a ball, it's around, you exert 80 to 100 microvolts, okay? When you chew food, it's around 150 to 200 microvolts. When you clench at night, so we do a baseline study before we switch on the unit and the patient goes to sleep. When you clench while awake, it's around 300 to 350. And when you clench at night due to a desaturation event, oh my God, it's almost 3 times. So you can actually combine the two in order and see when exactly how these desaturations come, tag along with the clenching force. So we have used this a lot and we come up with beautiful results. So what's the treatment? CPAP, oral appliances, CPAP plus oral appliance, surgical procedures. So again, another guideline that the right bite has come up with, if your AHI is between 0 to 35, oral appliances. I normally stick to 25. If it's below 60, CPAP. If it's above 60, CPAP, oral appliance, surgery. If it's above 85, I don't know how you're alive. You're just a zombie. Better get yourself something done, something, lose weight, do something. Please don't wait. Okay. So this is how a CPAP and oral appliance works. So CPAP basically pushes air through that airway to keep the tongue forward, and the oral appliances maintain the jaw forward. Okay. So there are several appliances out there. There are tongue retaining devices, there are fixed appliances, there are adjustable appliances. Somnomet is the most famous one, but it's not about the appliance. It's about the bite registration. I've seen research papers that show how important, how sleep appliances are, ending patients up in pain. Well, that's because they are all being taught to register the bite at 70% maximum protrusion. How can every human being have the same bite? How can that be even possible? Every human being is different. Right? Are you crazy? Seriously? You're not supposed to be doing that. So, which is why neuromuscular dentistry, they use the K7 or even the TENS, just the TENS. We can find out in live mode at which level the muscle is, at which jaw position. So you can see all these. So if this is the myotrajectory, so the occlusion should be here, the myocentric occlusion with the sleep appliance bite would be somewhere here, 1, 3, 6. So you can see in live which point has the least muscle activity. And that's where you record the bite, both in sagittal and frontal. So you should not be shooting bites. I've heard of even the lab, telling me some doctors just send the cast. Oh, come on, seriously, how can you just do that? Anyway, those patients, yes, they will end up with pain. If you do it this way, absolutely no chance. Sound sleep, keep your spouse and fellow passengers happy. Posture. The C1 is the atlas, it helps in rotating, and C2 helps in tipping. The most important part is why it is involved is because there is a research paper that shows that the occlusal plane has to be in line with the C1, C2 plane. So any change in that is going to cause some issues. Erect posture actually starts from the dental occlusion to the fossa, occiput, the shoulder joint, the spine, the hip joint, the knee, the ankle. Any change in that, you're going to see these issues. You even have patients having the head. So forward head posture would also be because to open up the airway, the body tells the head to come forward, so the airway opens up a little more. And then there's work posture with people on computer. They're always head forward, so that will also cause these problems. We use this technology in our Delhi unit with for our sports patients. Half the Indian cricket team, a few badminton stars, tennis guys, football teams. They're all wearing our appliances right now. We've not gone gung-ho about it because we just never had the time for it. But these are all measured stuff with the jaw in the right place. We use the MAT scan. I think I have an example here. Yeah, so you can see how the weight distribution is, how it's changed with the orthotic. The orthotic has been given, but before the TENS and the T-scan, we do the T-scan corrections, get it to almost 49 to 50, and then check the MAT scan corrections and see how it is improved to 51.49. So this is not done in like one day. This is over weeks. The patient keeps wearing, comes back, wearing. So it's painstaking, but it's amazing results. I'd like to end with a typical case. Patient came to us complaining of maxillary prognathism, although we did not find any much, but that's how kids these days are. So, but guess what we found on further questioning? There's pain, clicking, there's headaches, there's bruxism, attrition of teeth. Patient had sleep apnea. Patient complained of morning headaches. So we checked the pre-10 EMGs and then the post-10 EMGs. You can see all the muscles, how they relaxed here, especially the temporalis muscles. And then we did the tracking and found out how the jaw is now stable with the habitual trajectory. We made an orthotic, gave her an orthotic, asked her to wear for 6 months, symptoms subdued. It's a day and it's everyday thing that we see. Once the pains were off, we now had to get her into orthodontics. So what do? We basically cut the posterior part of the orthotic, wire the upper, and start supraerupting with elastics. Again, only on the 6s. We leave the 7s free. I think I have a photo of that. Yep. So physiological extrusion always is much more stable than a fixed extrusion, a forced extrusion, sorry. So till the 7s are not in position, we don't stop the treatment. Then we wire the lowers, and we then do the anteriors, and then we expand. So no matter if there is extraction or anything, finally we expand. Always expand. So not much in North India, but in South India, our Dravidian face polymorphism is more like a lot of prognatic faces. So you might need to do extraction and retraction, but always finish with an expansion so that you don't have to give a fixed retention and the patient with pain. The bite is stable, and we use a T-scan to finish the bite, and there's no retention appliance required. I have not given any retention appliances from the minute I started neuromuscular dentistry. A myriad of other neuromuscular disorders that a dentist can treat: TMD, OSA, CCMD, cluster headache, cervical dystonia, MPDS, Rhineck, even a Rhineck when a patient came in during a fishing incident, his neck just turned, and all because of a missing tooth. And we just tensed him, the head turned back normal, and he's on an orthotic and he's perfect right now. Palatal myoclonus, another case that I presented in Buenos Aires during the ICMO International Conference. So it's just amazing things that you get to see as a dentist. In short, to conclude, you need to de-learn, all that we've by-hearted and brainwashed ourselves in the final year of dentistry, and relearn our first year, second year subjects, and continue to learn. That's what I'm doing, continuing to learn. Just don't stop. And it's all about teamwork. You can't do this alone. So I kept talking about combination therapy. This is the combination. We need all of these guys. But because you're in India, you don't all have all of them. I have a chiropractor in Bangalore and Delhi and Mumbai. ENT, good ones. Neurologists, yes. We don't have a good podiatrist around, so kind of struggling with that. So what started out in my life as, with general dentistry, went on to occlusion, sleep apnea, posturology, and now I'm basically looking at general well-being, just a dentist. So think about it. I end my slides with this main take-home message. We are not just tooth doctors. As a matter of fact, I did not talk about this organization that we have. It's known as ICMO, International College for Craniomandibular Orthopedics, ICCMO. We are a group of dentists across the world, maybe around 800, that's it, who practice neuromuscular dentistry. We have a chapter in India that's very young, only 2 years old, but we have almost 60 members, so it's growing fast, really fast. And, you know, we'd like to see more new dentists or even dentists who have been practicing pain to come and relearn with neuromuscular and see how it changes your practice as an upgrade. We do conferences every 2 years, so if you have any doubts, please come online, icmoindia.com. I have my website, which is tmjindia.com. It's tmjindia.com. You can come on board and shoot me any questions. I could answer them anytime. So till then, dhanyawad, gracias, spasibo, shukran, obrigado, grazie, merci. Thank you.